Hello, everyone. I'm Charlie Reavis, president of Dysphonia International. I want to welcome you to our webinar today titled Ask the Experts Q&A session. We are recording the webinar and it will be available on our YouTube channel and our website, dysphonia.org. This is an opportunity for you to get a lot of your questions answered in person. And so we encourage you to submit lots of questions, but you can do that by typing them in again in the Q&A box on your Zoom screen. It's just, it's easier for us to track that instead of putting them in the chat box. So please type them in the Q&A box. We will answer as many of the questions as time permits. But I want to assure you that all the questions will be answered and included as part of the webinar that we post on our website, dysphonia.org. I'm pleased to introduce our guest experts for this webinar, Dr. Michael Johns and Lauren Timmons-Sund. Lauren is MSCC SLP at University of Southern California. Dr. Johns received his undergraduate degree from University of Virginia and his medical degree from Johns Hopkins University. He completed his training in otolaryngology at the University of Michigan and his fellowship in laryngology at Vanderbilt Voice Center. Dr. Johns founded the Emory Voice Center with Dr. Edie Hapner in Atlanta. And after several years at Emory, he moved to the University of Southern California to establish the USC Voice Center. Dr. Johns has a passion for voice research and has published numerous papers on care and treatment of voice. He is a founder and leader of Fall Voice Conference, and he is engaged and extremely active in all of the professional associations for voice. And I'm extremely proud and pleased that he is not only actively engaged, but enthusiastically engaged with our organization, Dysphonia International. Laura Timmons-Sund is a speech-language pathologist at USC Voice Center. Laura received a Bachelor of Music in Voice Performance from Illinois Wesleyan University. She received a Master's in Communicative Disorders from California State University, Northridge, and completed her fellowship in voice at the USC Voice Center. She also completed a Voice Center research internship at the University of Pittsburgh Voice Center. Lauren's specialty is the comprehensive assessment and treatment of voice and upper airway disorders. She also specializes in the care of professional and performing voice, and has much experience working with many people in the entertainment industry. So we will get started with the program. Dr. Johns and Lauren, to start off, I want to ask you a question that we get quite often, and I think it's one that's extremely important. Would you guys take a couple of minutes and talk about the difference between voice and speech?
This is such a great one. First, Lauren, I'm going to let you spearhead that one, but I wanted just to say thank you, Charlie, Kim, and Nicole, for asking Lauren and I to come and join. I want to thank everybody who's on the call who sadly can't see, but we look forward to answering your questions the best of our ability. This organization is so terrific, and caring for people with laryngeal dystonia and vocal tremor and all voice disorders is our passion. So thanks so much.
Yes, thank you for having us. So my question is, what's the difference between voice and speech, right?
Right.
Okay, so voice, when we think about voice, there are three subsystems that comprise the voice. Airflow has to come up from the lungs to vibrate the vocal cords or vocal folds, as they're more accurately called. And then we shape that sound through our vocal tract to produce voice. Really, when we're thinking about voice, typically people are often thinking about how is that phonatory system or that vocal fold vibration happening in the larynx here. But we can have voicing without speech. So I think a good way to think about that sometimes is like babies are making sounds all of the time with their voice, but they're not necessarily speaking. They could make all sorts of vowel sounds or various noises that are voiced. The vocal folds are vibrating. When we add the articulators into it to create meaningful sounds that we decode and interpret as language, that's the speech component. So the speech component adds the articulation part into it to shape the actual words that we're saying.
Okay. Maybe just, Lauren, comment a little bit on, for many of us, including myself, and I'm sure quite a few people on participants on the webinar, live with a voice condition, spasmodic dysphonia. So talk just a little bit why that's really a voice condition and not a speech condition.
Great question. So voice is part of speech in terms of we have voicing with speech. But spasmodic dysphonia or laryngeal dystonia, those are voice disorders versus a speech disorder is typically, characterized as the voice disorder because the abnormality is occurring in the larynx at that phonation level. So the vocal folds are either spasming together or spasming apart, and it's really happening in that vocal fold mechanism here. Now, it impacts the intelligibility of our speech and how well people can understand us, but the issue isn't in the articulators and the tongue or the lips or the palate. The issue of where things are not working how we want them to work is really laryngally focused in spasmodic dysphonia or laryngeal dystonia.
Great explanation.
Just to chime in, now, dystonias and tremors can also affect the oral area and the speech system. And so they can, and so it can, so it may be that speech can be affected if those structures are affected with either dystonia or tremor. But then we use different terms for that. When we talk about the dystonia or tremor affecting the larynx, it's laryngeal tremor or laryngeal dystonia. If it's affecting the mouth, tongue, and lips, we call that oromandibular. And so the two conditions can occur simultaneously. But nice summary, Lauren, of that. Thank you.
Yes, thank you for adding that, because I'm sure that there are some people tuning in who have that overlap of some of their articulators being impacted.
Excellent discussion. Thank you. Question is stated pretty simply. So it said, Botox, worth it or no?
That's a good question. And I would say for people with adductor type spasmodic dysphonia, Botox helps people's symptoms remarkably the vast majority of the time, provided you're getting technically accurate injections at a dose that has been well thought out and well communicated. That is indeed the case. And we wish we were all as straightforward and simple, because then we would be able to say everybody gets better with Botox. But the reality is that it's not as simple as that, because the other types of spasmodic dysphonia, which sometimes can be combined with the most common form, the adductor type, when we have other forms involved or tremor involved, the treatment results are usually helpful, but sometimes not as good if it's just adductor type spasmodic dysphonia. The question is why. And so when the vocal tract, or everything above the vocal folds, is involved with either tremor or dystonia. That affects voice and sometimes speech. And that's an area where we can't meaningfully place enough Botox to improve voice without impairing speech or swallowing. And so it's an area we just can't effectively treat with Botox. So if the problem is primarily involving the vocal cords themselves spasming together, the vast majority of people will have significant improvement with Botox. So it's worth it most of the time, I would say, because that's the most common presentation.
So, Dr. Johns, with the Botox injections, do you get scarring from those injections?
Yeah, no, typically not. And it's an injection through the skin into a muscle. So similar, I mean, it's more complex and more technically challenging, but similar to an IV being placed or an arm or an injection in the arm, where we typically don't see sort of scarring over time.
Okay. Very interesting question. Do you believe the thalamus controls part of speech?
All right, well, now we're getting deep. So first disclosure, I'm not a neurologist, so I'm a larynx specialist. And certainly voice and speech control in the brain is incredibly complex, from auditory feedback to motor planning to ultimate control of your laryngeal muscles and then your articulators to produce voice and speech. It's very complex. And so it involves many parts of the brain, including our feeling system, because we need to feel where our tissues are in space and time. I'm sure people have had an experience when sitting in a conference room or in a position for a long period of time where a leg may go numb. And then you have a really hard time controlling the motor movements. And so the feeling plays a role with the motor function, and that's all integrated in a complex neural network in the brain. And so this is what we're trying to decipher. Now, we, meaning the field, is trying to decipher to improve treatment. Lauren.
And I'll just add for anyone listening who is like, what's the thalamus? So the thalamus is a part in the brain that's kind of a relay center for information. So Dr. Johns is talking about the sensory systems because sensory information is going to go through there for the brain to interpret. And so that's why he's saying, you know, can you really separate out something as complex as voice and speech from that process? Probably not. I'm also not a neurologist, and so full disclosure on that. But if we know the auditory system and what we feel impacts our motor capabilities, it makes sense. That's where this question is coming from. And so for anyone who's not familiar, the thalamus is helping process all of that kind of sensory information coming in.
So, Lauren, that leads to another question in terms of treatment. So how does, and I'm going to throw you perhaps a bit of a curveball, I'm going to say, how does voice therapy work in conjunction with other types of treatments like botulinum toxin injections?
That's a great question. I think that it's multifaceted. You know, we typically don't advertise voice therapy as a primary treatment for spasmodic dysphonia or laryngeal dystonia, primarily because it's not eliminating the problem. That being said, it can be really valuable for some people. If voice therapy were to resolve the problem entirely when we think the diagnosis is laryngeal dystonia, really then we're looking at, okay, well, that probably actually wasn't what was going on. It was probably a primary muscle tension dysphonia masquerading as a dystonia, and that happens sometimes. But let's talk in the sense of truly it is a dystonia and that's what's going on. Some people find that the Botox isn't worth it. You know, Dr. Johns was talking about Botox is helpful for most patients, and that's true. That's my experience as well. Sometimes it's not. And people just need strategies to optimize their communication. How can I make sure people understand me as best as possible? So I'm repeating myself as little as possible. How can I make sure that I'm not as fatigued when I'm speaking? So we can work on strategies in those senses where maybe someone's not receiving Botox, and we're just trying to kind of problem solve and compensate for the problem that exists. Other times people are getting Botox and they're sounding better, but they're saying, you know, I feel like it could still be a little bit even better. I still feel fatigued when I talk. It's effortful. Then we may do a short course of therapy after the Botox to kind of maximize the gains, learn strategies to not use our voice in such an effortful way, to keep things relaxed. And I find that most people benefit from that. And I'm talking like 1 to 2 sessions of learning strategies to learn, you know, how do I breathe the best way to support my voice or make sure I'm not doing anything funny with that? How do I avoid pushing in the throat too much to make the sound come out? So that's kind of what we do in voice therapy. And I think that it can complement the Botox. I also have a lot of patients who don't need it. So it's very individualized.
You mentioned muscle tension dysphonia, which is not a neurological condition. It's a condition of abnormal vocal posture that can lead to symptoms, just like a bad posture that I have can lead to symptoms. Now, that being said, most people who have laryngeal dystonia will have some muscle tension components. And think of it a little bit like this. If you have a movement that's happening in your hand, it's involuntary, it's pretty common to try to stabilize that by recruiting muscles that are outside of the muscles that are moving. And so if things are moving in the larynx, it's not uncommon to try to recruit some muscles to try to control things, often in a maladaptive kind of way. So there's a little overlap there.
Right, right. And I'd say many people have that secondary muscle tension, and that's kind of what we can address in voice therapy.
So as we're kind of focused for this portion here for a few minutes on injections and Botox and so forth, what do you guys see as the most common side effects from Botox injections?
Yeah, so Botox works by weakening muscle. And so it's not a filler material, it's not a plumper like Juvederm or Restylane. These are common cosmetic products, but Botox is also a cosmetic product in some senses, but started out as a therapeutic for neurologic disease. But it works by weakening muscle. And its effect isn't exactly the same over time. It's not like an on-off. There is a dose response where we deliver Botox typically to the muscles of the vocal folds that are bringing them together, causing spasms. We inject Botox there, which reduces their ability to come together. The more we give, the less they'll be able to come together. And so the resulting side effect initially when the Botox takes effect, typically about 3 days after the injection, the Botox has its maximal effect and you can have soft and breathy voice, even to a whisper. And that can occur in variable degrees. Also, when the vocal cords or folds can't get fully together, you're more prone to choking on liquids because things that move really fast, you know, we use our larynx to protect our airway. So those are the two most common side effects: breathy, soft voice, and occasionally choking on liquids. That's related to the dose of Botox that we give. But here's the kicker. Very few medications have such a wide therapeutic range. I have patients who I give 0.1 units and they have breathy side effects. Similarly, I have patients who I give 7.5 units and they have very little side effects. And so there's not many medicines that are out there that have an order of magnitude or almost 2 of differences in dosing. And there's no formula, height, weight, gender, to figure out the math, and people's sensitivities are different. There's another variable, of course, is our accuracy of our injections, and so there can be some variability time to time. But this is where the art of Botox really matters, because shared communication, close communication, logs and tracking, having our patients be empowered with knowledge so they can come into the appointment and say, hey, that was 3 weeks of breathiness, it was too much, I think we need to decrease the dose to this. And we're very receptive to that. And in fact, we want and encourage that.
Yeah, and Dr. Johns, I think that along the lines of what you're talking about, a good point to make for people who are newly diagnosed and maybe who have not tried Botox, or maybe have tried it once or twice and didn't feel that they got the result that they were looking for. But I think it's just what you're saying. It's important for everybody to realize that this is not an exact procedure in the way you described it. So I would encourage people, please don't give up. Work closely with the laryngologist to try different dosage levels and whatever, as Dr. Johns talked about.
I tell patients it may take about a year to figure out the right dose, sometimes a little bit longer. Sometimes we get it right on the first go. But if your clinicians aren't communicating with you and empowering you with the knowledge and tracking things so you can work towards better and better, then you want to find someone who will.
Excellent. Thank you, sir. Interesting question. Which voice clients or patients are best candidates for laryngeal function studies?
So laryngeal function studies is the term that we use to describe acoustic and aerodynamic assessment of the voice. So that's using instrumental assessment to take measures such as fundamental frequency, intensity. There are some more complex acoustic measures like kestrel peak prominence. And then aerodynamic measures are measures of air flow. So that's like the amount of flow through the vocal folds as they vibrate, the pressure below, etc. So these are really diagnostic tools that we use. They can be used before therapy to help inform therapy. They can be used afterwards to measure change. And so I'd say it's really variable. You could use it with any client. You're typically not going to be using it over and over. You typically use it before treatment and potentially after treatment to measure outcome, if you think it would give you valuable information. So I would say, in our clinic, if someone's coming in with a diagnosis of spasmodic dysphonia, we typically aren't doing those studies because it's not going to significantly change our treatment. That being said, I might do that study for someone with spasmodic dysphonia if, let's say, I notice they're really holding their breath and it seems like that's negatively impacting their voice outcomes. We're doing botulinum toxin injections and the spasms are better, but I'm like, you still sound pretty strained and like you're holding your breath. Maybe I would do some laryngeal function studies to see if that reveals anything for me about how that patient is managing airflow. So it's really dependent in terms of, is there something that I'm trying to suss out diagnostically that would help inform our treatment?
Excellent. Good explanation, Laura. Here's a very interesting question. What kind of age-related voice conditions would you utilize laser therapy and vocal cord injections?
Yes, okie dokie. So when we're using lasers in surgery in general, it's a surgical tool that we're using to cut or ablate something. So if there is a growth, whether it's benign or malignant, lasers can be very helpful as surgical tools to remove that when surgery is indicated. Now, we don't use those for age-related changes alone. With age-related changes, we get global weakness that ensues, our muscle mass decreases. Some things get dry, our mucous membrane lining gets dry. Some things get saggy, the vocal folds become more floppy. And so they don't meet as well, and they don't vibrate as regularly. And so sometimes we'll do vocal fold injections with fillers to improve the way the vocal folds can meet and close, and then hopefully vibrate better. And so those are the times that we're using filler materials for things like paralysis of the vocal fold, paresis, which is partial paralysis, or atrophy, which is the word when the vocal folds become symmetrically weak. And so we'll use those procedures for that. Now, as it pertains to spasmodic dysphonia or vocal tremor, as we gain wisdom in life and the years go on, we can develop some age-related changes as well. And they typically present with a softer and weaker voice. And so there's some competing treatments here that when we're using Botox, which makes things weak, if we're weak already from age-related changes, we've got to be cognizant of that because side effects of treatment might be worse. You may be more sensitive to breathiness or choking on liquids. And so we want to use judgment and use a lower dose. And so age-related changes aren't a contraindication to treatment, but it becomes more complex when you have multiple things going on.
So you touched on vocal fold paresis, Dr. Johns. Could both you and Lauren talk more about the treatment options for vocal fold paralysis and paresis?
All right, I'll start on this one. So when we have a paralysis or a paresis that is caused by injury to the nerve that's controlling vocal cord movement, and that can be thyroid surgery, it can be spine surgery, sometimes it's chest surgery. And so when a vocal fold is paralyzed, completely immobile, and there's a space between the vocal folds such that you've lost your voice to a whisper, or partially mobile, meaning it's not fully moving, but it has some motion, what we're looking for is how close and how completely the vocal folds can meet and touch. And so when we see patients who have vocal fold paralysis and paresis, Lauren and I at this point in time in the clinic can kind of communicate just with our eyes knowingly about how big the space is between the vocal folds and how soft and breathy the voice is as to whether there'd be any benefit whatsoever from voice therapy. So voice therapy, I'll let Lauren talk about that. So if there is a big space between the vocal folds, we'll typically start with vocal fold injections if there's a chance for recovery of that paralysis or paresis, filler material injections, not Botox. Or if there's no chance for recovery, we're commonly doing an operation called a thyroplasty, which is an implant procedure to push the door over, kind of like you're closing a door with a door shim. But if the vocal folds are meeting pretty well, smashing them together further sometimes can make things worse, in which case we may apply voice therapy. Lauren.
Yeah, so voice therapy is a little bit different looking, I would say, for vocal fold paralysis versus paresis in some ways. Overall, what's the overarching goal of voice therapy in general, regardless of problem? I tell patients really simply to make your voice feel better, sound better, or both, right? Regardless of what the problem is. That's what we're trying to do. In the case of a paralysis, when the vocal fold can't move, neither the filler material nor voice therapy will make that vocal fold move again. If it's going to move again, the body is going to heal itself and do that. If the gap between the vocal folds, because one doesn't move, so one moves and one doesn't, if the gap is really big, voice therapy is not going to be very helpful. So that's where that eye contact with Dr. Johns comes in, of where this is where injection would be helpful. But let's say the patient has had an injection, so the vocal folds can now meet better. This one that doesn't move has been moved over so that the one that moves can touch it, either through injection or through a thyroplasty. A lot of patients at that point don't need anything else. A lot of patients, though, do need voice therapy afterwards because they have been compensating for a voice that wasn't working very efficiently. And Dr. Johns mentioned earlier about something else, maladaptive compensation. We tend to recruit extra muscles. We may be pushing our air in a certain way. And so we may still have some roughness to the voice potentially, or some strain, or we may just feel a lot of effort. And so in voice therapy, we're working on coordinating the voice subsystem so that it's the right amount of airflow and air pressure with the right amount of engagement of the vocal folds without too much extra muscle tension, with the right resonance, so that you get the best sound and feel possible. It's a similar situation for paresis. Paresis is a little bit more murky because there's more variable in that. It's a little easier almost when you say the vocal fold's not moving. That is what it is. Paresis can be pretty variable in terms of voice therapy might be the primary treatment for some of those people if it's a pretty minimal paresis. But again, we're working on that coordination of the voice subsystems and kind of working on optimizing the interplay among those.
Okay, excellent. Just maybe elaborate a little bit more. I know both of you have touched on vocal tremor. And of course, there's the big question always is, is it essential tremor in the voice, or is it dystonic tremor? And how do you differentiate and so forth between those? But could you guys talk a little bit more about the treatment options for people with vocal tremor? Because I'm not sure what you guys see in your clinic, but I've had a lot of laryngologists and SLPs tell me that they see as many as 25, 30, 35% of people with spasmodic dysphonia also have some type of tremor in their voice.
Yep.
Yeah, do I want to break this down to Dr. Johns, kind of how you approach it and then what we do if voice therapy gets involved?
Perfect. All right. Yes, indeed. So tremor and dystonia. Tremor they're both conditions of the brain. With tremor, abnormal movements happening in a very regular kind of way in the voice, versus dystonia, where the muscle spasms are happening in irregular kind of way, not and at more variable times. Now, it may be one condition that presents in different ways. It may be two different conditions that overlap a lot, because you're right, a lot of our patients with spasmodic dysphonia have vocal tremor. And tremor comes on as we get older, typically. And as our population has grown in its lifespan, we're seeing more and more people with tremor and vocal tremor in general. And it's more complex. It's more complex because it's not just involving the larynx. Commonly, the throat wall, the back of the tongue, the palate is involved with the tremor, like the whole horn, if you will. If you think about the larynx as a mouthpiece and the vocal tract as a horn, the whole horn is shaking commonly. And the larynx can have tremor in different domains as well. So treatment for tremor can be medical treatment, procedural treatment, or behavioral treatment. So the medical treatment is most commonly prescribed by neurologists, and I do recommend my patients with tremor see neurology because medical options can be effective. These are medicines like propranolol or primidone, amiceline, and these are tend to be quite effective for hand tremors, but are thought to be less effective for tremors that we call axial tremors that are in the center of the body, like vocal tremor. That being said, we did a comparative study between Botox and propranolol a number of years ago, and half of the people with vocal tremor had some benefit from propranolol. And so we don't rule out medical treatment, and I think it's worth a try, and typically best prescribed by a neurologist. Now, when it comes to our easily accessible treatments, Botox, like I was mentioning earlier, we can really only effectively inject Botox into the vocal fold and laryngeal muscles. Attempts have been made to inject, and I have done this, in the strat muscles, which are in the front of the larynx, or in the muscles above your wishbone, the hyoid bone, these muscles at the base of the tongue. But the problem is these are big muscles. And so to weaken them enough to reduce those symptoms, it comes with a lot of problems of swallowing and speech. And so that's experience, and some other experts may feel differently. I really don't think there's a lot of value to be gained in Botox to these structures. And so tremor symptoms can persist despite treatment. Now, Botox is great at eliminating spasms of the vocal cords together. And so if tremor becomes severe such that the voice is cutting out or nearly cutting out, then we can eliminate that and get a more kind of a where the tremor is still present, but the stops of voice are not, and then voice is more intelligible. That being said, voicing and speech, it comes out automatically. It's something we don't really think about, which is one of the most frustrating things for people with voice and speech disorders in general, that you have to kind of start thinking about things. We commonly think that all of this is out of our control because it happens automatically, but it's actually really not. And we can gain awareness of all our subsystems can improve the way we communicate. And so voice therapy does play a role for patients with vocal tremor, and certainly in certain situations.
So, Dr. Johns, before Lauren comments, could you kind of clarify a little bit when people talk about they get injections in their false vocal cords?
Great. Good question. And so this is a treatment that I will do as well. So the true vocal cords contain most of the muscles that bring the vocal folds together. And the false vocal folds are folds of tissue above the true vocal folds, a little higher up, that really don't contain much muscle in them. However, Blake Simpson was one of the first to describe this, and then I subsequently have done this fairly frequently, is injecting the Botox into the false vocal folds and not the true vocal folds. We're actually not really injecting it into muscle. We're just putting it right under the epithelium or the skin lining of the false vocal folds. And it works. The question is we don't know why. So Botox can affect some of the feeling systems, and we know that feeling in the throat is important for production and motor control. So maybe it's affecting that system. Now, there was an interesting study at the Fall Voice Conference, very simple study that was done out of New Orleans, where they were doing a cadaver dissection, and they injected a dye into the same place that we put in for false vocal fold injections, and they just watched where it went. Some of it actually, it does trickle down into the muscles of the true vocal folds. Now, it's not a perfect connection to a larynx that's in the body with blood flow and all that, but it's likely that this is just a slower, more global weakening of the compartment of the larynx that brings the vocal folds together. And we tend to have to use higher doses to get the result. But if you use a real high dose, you can get breathy voice just like when you stick it into the true vocal folds themselves. And so basically, I apply that technique when Botox is effective, but there's a lot of side effects, a lot of breathiness, and the positive effect is pretty short. We'll try a false vocal fold injection, which tends to have less side effects and may give a more durable effect. Fair enough?
Yeah, good explanation. Thank you, sir.
Right.
So the voice therapy component, right? Is that what we want to hear about?
Right.
So, Dr. Johns was talking about how sometimes we do use Botox when there's tremor at the level of the true vocal folds, and that will smooth the tremor some, but not completely eliminate it. Or there can be tremor, and often is tremor in these other structures that are not really injectable with Botox due to the negative side effects that would happen. So those patients can be good candidates for voice therapy. And voice therapy is sometimes also used as primary treatment, even when there is tremor at the level of the vocal folds. There is some research, and I'm sure there's multiple groups that have done research, but Dr. Julie Barkmeyer-Kramer is one person whose group I know has done some research on voice therapy for vocal tremor and reducing essentially the auditory perception of tremor. And what that means is the tremor is not being eliminated. It is there still, but it is becoming less perceptible to the human ear. And we can do that by modifying some of the components of speech. One of those is to avoid prolonging vowels and slowing down the rate of speech. There's a little bit of research that shows that kind of at baseline, people with vocal tremor tend to talk a little bit slower and elongate their vowels. Now, if you're elongating your vowels and there's tremor, there's going to be more opportunity for someone, including yourself, to hear that tremor, right? Because if you're holding out just E real fast, you might not hear any tremor. But if I go E and I have tremor, you're going to hear that E, right? So in voice therapy, we will work on kind of quick, clipped, short phonatory segments. So what that means is that we are not doing this long, drawn-out legato kind of speech like this, where my tremor could become really obvious. We'd be talking a little bit more staccato like this with short phonatory segments so that that tremor isn't getting in my way as much. We'd also focus on other components that kind of always get woven into voice therapy of doing this with low vocal effort so that we don't feel like we're straining in the throat here. So I have found that this can be very helpful for people just so that it feels easier to talk. They're more intelligible. The tremor is not in the way as much. But it doesn't eliminate the tremor. It just makes it easier to communicate with the tremor to feel better.
Excellent. Great discussion and a lot of good information on these topics and these conditions for people. Where was it? I just saw something that triggered it. Oh, this person is asking a very interesting question. In your experience, do people develop dysphonia often after stressful experiences or more often after illnesses?
Yeah, we don't really know the answer here. So we're talking about dystonia now. We're talking about spasmodic dysphonia, which is dystonia, not dysphonia in general, which is a generic word for voice change, because lots of things can cause voice change. When we talk about the dystonias, we don't have a good sense of what causes it. Things are normal, something happens, and things are not. And people have associated this sometimes with an illness, sometimes with a physical trauma or emotional trauma. So I've heard patients describe having anesthesia. Certain medicines are known to cause dystonia, but we don't know. And so we don't even have good data on that from people who have spasmodic dysphonia. And actually could be an interesting study, Kim, that we probably could get some updated information on that. Let's pencil that one in. So thank you for that. But we really don't know for sure. But the idea is that some people's makeup puts them at risk for developing some of these conditions. And then something happens, an event, that triggers a change in the network, the neural network, in this case, that controls voice. And then you develop this condition that is irreversible.
Interesting. I think there was 2 or 3 questions that I've seen too, where people are asking, if I don't get treatment for my, and I'm just going to characterize or generalize voice condition, will it get worse?
Okay, so first and foremost, if you have voice change, you need to get a diagnosis. Voice change lasting longer than 2 is not acute laryngitis, like viral laryngitis. So you need to get a diagnosis, and getting a diagnosis requires laryngoscopy, looking at the organ involved, for one, and of course, a careful history and medical examination in general. And that's done typically by ear, nose, and throat doctors. And for voice conditions, better yet, by people called fellowship-trained laryngologists who just do throats. And we use specialized tools and lights to get an accurate diagnosis. That's the key number one, get a diagnosis, because some things is reassurance. Voice change is not bothering me, it's age-related, there's no cancer. Doc, I don't like your scope, I'll see you if anything changes, okay? Or there's conditions like spasmodic dysphonia, which typically have a period of getting worse and then seem to be stable and don't seem to progress terribly or change one way or another unless something new were to come into the picture, like age-related changes or tremor. So that's sort of the scenario there. So starting with an accurate diagnosis is key, because some conditions, like precancerous conditions, can progress into cancers. And so.
Right. This is an interesting question, Dr. Johns. This person is saying they are currently receiving Xeomin, and their question is, what injections are most effective?
Yeah, so Xeomin is another form of botulinum toxin type A, and we have an available botulinum toxin type B, and they all have the same effect of blocking the signal from the nerve ending to the muscle. That's temporary. And Xeomin and Botox, they're substitutable. And there is a conversion for one to another. It's not perfectly precise. So if you're having to switch from Botox to Xeomin, sometimes this is out of control of patients. The pharmacy, either at the hospital they go to or for their insurance, changes and says, okay, we're not doing Botox anymore, we're only doing Xeomin. And so we have to do the calculations and then do a little bit of trial and error. But they all work fundamentally the same, and in the reported literature, about the same length of clinical effect. But the new kid on the block is, if you will, is a botulinum toxin that has been modified called Daxxify, and it seems to have, there's some evidence that it may have a longer clinical effect. And so this is kind of, stay tuned, it's on the horizon. There's research underway that is supported by Dysphonia International. Thank you very much. And so it is possible that we may have a treatment that is similar to the treatments right now, but it just lasts a little bit longer, which would be just, a benefit to everybody. But it's not a cure. So that's sort of the scoop with that. And in fact, I've heard recently these discussions in our pharmacy about they may be considering changes, and and so we're all pushing back and whatever. We want to have options as clinicians. I'd like to have all of them available. So if a patient comes to me and they've had Xeomin, I should be able to give them that. But sometimes I don't get a say.
Right. Well, hey, keep pushing back. Interesting question that I hear quite often. I'm sure you guys do too. Is there any connection established between spasmodic dysphonia and Parkinson's disease?
So again, not a neurologist, and so I speak from peripheral knowledge, because I take care of a lot of people with dystonia and with Parkinson's as it relates to the throat. So they are separate conditions or different diseases of the brain, but they're both central brain diseases, but they're different diseases. And now they each can have a lot of variance. So with Parkinson's, the presentation in the larynx typically is one of significant vocal atrophy. It looks like really bad age-related changes where people's voice becomes softer. and the vocal cords are atrophied. And our treatment for that is actually voice therapy, strengthening exercises, because these patients can do better than they think they can. And it actually has been just proven straight up to work. And sometimes we'll inject those vocal cords with filler. But Parkinson's can have variants that have kind of spastic components or tremulous components. And so sometimes those components can be treated with botulinum toxin or fillers. And we do that in a shared way with our motion disorder specialized neurologists, because they'll be able to what's happening with their overall disease state and treatment, and then I can target sort of specific symptoms that I could help with procedural treatment.
I think the other thing to just keep in mind when we're thinking about those two different entities, as Dr. Johns mentioned with spasmodic dysphonia, there's a period of it getting worse and then kind of stabilizes. Parkinson's disease is unfortunately a progressive condition. And so if voice and speech are progressively getting worse, that is a concern. And voice and speech therapy are very helpful in that sense. There are speech changes in Parkinson's, and so we target that as well.
Excellent, good points. We've kind of touched on this a little bit, but I want to get you to talk just a little bit more about it. As we know, there are a number of people in our community with abductor spasmodic dysphonia, and they are very difficult to inject, as Dr. Johns has talked about. So this person is asking, do you have any suggestions? What's the next recommended treatment option?
Yeah, so abductor type spasmodic dysphonia is hard to treat. So the vocal folds are spasming apart, and you get breathy breaks as opposed to tight breaks. And so the reason why it's hard to treat is threefold. Number one, they're hard injections to do. These muscles in the front are quite easy for us to access most of the time. To go behind the larynx, they're more uncomfortable. They're technically just harder to do. And so there's a technical component that brings variability. Then we're dose limited. We're weakening the muscles that open the vocal cords and allows us to breathe. There's a point where they won't open enough and you've got stridor and difficult breathing problems. So we're dose limited. In fact, to get successful treatment, I want my patients to have a little bit of breathing restriction. Nothing that's keeping them up at night, but something that may slow them down on the treadmill, because that's where we're going to get good results. And the third piece why it's is that patients can't compensate. When the vocal folds spasm together, you can push more air and force those vocal folds to vibrate. So you can compensate. And patients with adductor type spasmodic dysphonia typically will report that their voice will get a little bit better if they really push it. Now, when the vocal folds spasm apart, there's a gap between them, and a patient can push as hard as they want and no sound's coming out. And so it's hard to compensate for. So in situations where it's challenging to treat, and sometimes it can be so bad that treatment is just not effective. But Botox works for about 2/3 to 3/4 of people, in my experience, with abductor type spasmodic dysphonia, maybe even a few more. But it's a commitment. They're tough injections. Good communication is important. Checks to make sure the treatment worked is important. So when we treat they inject the adductors, we know the treatment worked if the voice gets softer. We know it technically worked. When we inject the muscles for abductor, the PCA muscles, we know it technically worked if the patient's having some breathing difficulties. But otherwise, we got to do a scope. And so it's a lot early on while we're figuring it out. An evaluation, a Botox injection, a quick follow-up visit to see if it even worked or not, boost it, and a little bit of trial and error over time. But usually, most of the time, we can get meaningful improvement in symptoms such that people come back for treatment. I mean, no one wants that.
Here's a, a question that I hear from time to time from people. And the person is saying, I received Botox with good results for over 25 years. Over the last few years, the Botox is no longer effective. My physician has tried different drugs with no effect. Do you have any recommendations? Because at this point, I'm having difficulty speaking.
Yeah, frustrating. And sometimes we see this happen. And the question, of course, is what's changed? Why was it working before and not working now? And so you want to have a good understanding of kind of what the diagnoses are now, because it could be multiple things. Tremor components can come in. Age-related changes can be very significant. So communicate with your doctor to really kind of understand what's changed. And second opinions are okay. I encourage my patients to get second opinions if we're not figuring it out. And we know who the folks who are generally do a lot of this are our fellowship trained laryngologists. So it's okay to get a second opinion as well.
Excellent. Thanks, Dr. Johns. This is and you've talked a little bit about this. I have vocal cord paralysis and had filler last year. Prior to having a filler, I had a gasping breath occasionally. This stopped after the filler, and now a few months later, it has returned. Is this caused by the vocal cord paralysis?
Sometimes it can be. When we use our vocal cords much more than we think we do. We think that it's about voice, but it's swallowing protection too. But we do it with exercise and lifting things. So people feel short of breath with a vocal cord paralysis, even though there's plenty of breathing room. And so sometimes a gasping breath can happen as a refill because air is leaking out. You can feel that, and that can improve when the vocal cords are meeting well. And then with filler materials, none of them right now are permanent, so they start to absorb. And sometimes the vocal cord will stay put, and sometimes it sort of drifts back to where it was, and you can start having symptoms. So it could be an early sign of that material being absorbed, and it's a good time to check in with who's caring for you to take a look.
This is an interesting, really more a statement than actually a question, but the person is saying that their voice is much better, almost normal, when I visit India. Is it weather or change in stress level? Any thoughts?
I think that would depend on the etiology of the source of the voice problem to start, because we don't have any info on that, right? But I mean, in general,
we don't know, Lauren.
We don't know, right? So, environment can make a difference for people in terms of stress level can make a difference. Environmental things like weather can make a difference, but it would be hard I personally would have trouble answering this without knowing what the cause of the voice change is for this person.
And if there's language differences too, sometimes people can have more symptoms speaking one language versus another. Otherwise, the sort of stress and environment would be the two sort of factors that would come to mind, because in general the disease states in the larynx don't change a lot in location, but humidity makes a difference. It's a dry climate here, and so creating a healthy environment in the larynx wherever you go always makes sense. Having good oil in the engine.
Okay. I think we're going to kind of wrap up here, but there's one question here that I'd like you guys to comment on. If therapy doesn't work for MTD, how often does Botox help, or how often do you think it is even tried?
Depending on the character of the muscle tension dysphonia, failing voice therapy, sometimes first we revisit our diagnosis, because it should get better with with voice therapy. So we're working together. We're trying to decide. But sometimes we'll give Botox a try because dystonia can present differently, and sometimes it's not just spasms of breathiness or tightness. Sometimes it's a chronic constriction, like a tight sound. So Botox trial, it's very safe to do. And so we do that from time to time. Now, here's the thing. If the Botox works and helps, technically successful injection, and then it helps, and then when the Botox wears off, it gets worse again, it's not muscle tension dysphonia. But if it gets better and then stays good, then you've kind of reset the system for whatever reason, and you're kind of back to baseline, and you're good. But we do that not infrequently.
Right. Just an interesting thought as you were talking, Dr. Johns. Do you think there's a condition that's really idiopathic MTD?
I guess it would. We'd lump that into primary MTD. In our field, we tend to talk about primary, where it's just kind of started, versus secondary related to something else. Oh, for sure, there's primary MTD, and we just see it a lot. And sometimes it can present very severely, such that we can have dramatic voice improvement, even in the very first office evaluation. Well, we meaning Lauren and the patient. But what I like to think about this is the posture analogy, because I've got bad posture. If I'd listened to my mother, I would have better posture, and I would probably have less. I've got back pain. I've got like legitimate musculoskeletal issues that I'm not doing great self-care for as a busy doctor, but it can feel like that, right? I can get symptoms from kind of a bad posture, and so that's how I like to think about primary muscle tension dysphonia. And you get lots of symptoms from just beyond just voice change, fatigue and discomfort and throat clearing and feeling like something stuck in your throat. So I'm a believer.
Yeah, I would agree with that. The description of primary muscle tension dysphonia is how we usually describe it, versus the idiopathic. Though, it is idiopathic in terms of we don't understand at this point why some people have primary muscle tension dysphonia and other people don't.
Right. Well, okay, guys, wow, it's time goes by so fast, and you guys were terrific. And I know we have quite a few questions that we didn't get to, but for everyone on the call, please be assured that Lauren and Dr. Johns has agreed to answer those questions. And as I said earlier, they will be part of the webinar on our website. So I just want to really thank Lauren and Dr. Johns for participating with us in this webinar. It's been fantastic, a lot of great information that you guys have shared, and extremely helpful. And I really appreciate all of you folks participating and attending these webinars. So as we wrap up, Lauren, any comments?
I just would like to say thank you, Charlie, for hosting us, and to Dysphonia International for the invite, and for everyone who's listening on the webinar and who submitted the questions. Thanks for submitting those questions. I think it's a benefit to a lot of people, and we're happy to be involved.
Fantastic. Dr. Johns, any closing comments?
This was a delight. The hour flew by, and thank you for including me. The goal of Dysphonia International and the academic medical community in general is to seek better treatment and get cures. And that work is complex, but it's ongoing, and I'm hopeful.
Thank you very much, sir. And again, can't thank both of you enough for all your support for not only our organization, but all you do for the people living with voice conditions, whatever those are. So thank you much, and you guys take care, and we'll do it again.
Thank you.
So long.